This presentation covers the surgical management of craniopharyngiomas. These are benign epithelial tumors that develop in the sellar and suprasellar region, next to the pituitary gland and optic pathways. Although the cells themselves are not malignant, their location can disturb vision, hormone balance, and sometimes cognitive function. If you enjoy learning practical neuroscience topics like this, consider joining the StudyNeuro community for high-yield education and clinical pearls. You can find us on YouTube, Facebook, TikTok, Instagram, and X. Stay tuned for more neuroscience content coming soon. By the end of this session, learners should be able to explain the main goals of craniopharyngioma surgery, identify key anatomical structures to preserve, describe common surgical approaches based on tumor location, and recognize the limitations and complications of surgical treatment. These tumors grow slowly, but sit next to critical brain structures. That makes careful planning essential. Surgery is usually the main treatment, while radiotherapy or cyst drainage may be added when complete removal is unsafe. The central goal of surgery is maximal safe tumor removal. Surgeons aim to remove as much tumor as possible while protecting surrounding brain tissue. Safety guides every move. If the tumor adheres to the hypothalamus, optic nerves, or major vessels, further removal could cause serious neurological injury. In those cases, surgeons stop and may use subtotal resection followed by adjuvant therapy, often radiotherapy, to control residual tumor growth safely. Two practical questions guide the operation. Where should the approach begin? The entry point determines the safest corridor to the tumor. When should removal stop? If the tumor capsule is firmly attached to critical structures, continued dissection could cause permanent harm. Stopping early protects the patient. Protecting critical structures is the first priority. The hypothalamus regulates temperature, appetite, and hormone balance. The optic nerves and chiasm carry vision signals. The pituitary stalk connects the hypothalamus to the pituitary gland and controls hormone release. Major arteries, like the internal carotid, and their tiny perforating brooches supply deep brain regions. Damage to any of these can have serious consequences. Preoperative assessment is crucial. Visual field testing identifies deficits that may influence surgical planning. MRI provides detailed anatomical information, revealing tumor size, location, and relation to nearby structures. Yet MRI has limits. The boundary between tumor and hypothalamus is not always clear, and compression may look like invasion. Often, the final decision about how much tumor can safely be removed is made during surgery itself. Endocrine evaluation is another key step. Adrenal insufficiency must be corrected with steroids, which act quickly. Hypothyroidism takes longer to adjust. Untreated hormonal problems increase surgical risks and may worsen outcomes. Choosing the surgical approach depends on tumor location, size, extension, relation to the optic apparatus, and position relative to the third ventricle floor. Tumor texture and calcification also guide the techniques used. Every tumor is different, and each patient's anatomy dictates the safest path.
Now we turn to surgical approaches based on where the tumor sits. Tumor location largely determines the safest and most effective route. For craniopharyngiomas that sit entirely within the sella, known as intrasellar tumors, the preferred method is transsphenoidal surgery. This can be done with a microscope or an endoscope. It gives direct access to the sellar region. Brain retraction is minimal, and surgeons can carefully identify and preserve any remaining pituitary tissue. This approach works best for tumors that are purely intrasellar or mostly cystic, with only a small extension above the sella. Patients lie on their back with the head slightly lifted in what surgeons call the sniffing position, which improves venous drainage and visualization. Sometimes the tumor extends above the diaphragma sellae. In those cases, an extended endoscopic approach may be needed. This involves removing some bone above the tuberculum sellae and widening the sphenoid sinus to get a better view. The tumor is carefully debulked, which lets the surgeons see the optic chiasm, perforating vessels, and the interface between tumor and optic apparatus. Whenever possible, the pituitary stalk is preserved to maintain hormonal function. Closure and reconstruction are key steps after surgery. One major risk is cerebrospinal fluid leakage. Surgeons often pack the sellar cavity with fat, reinforce it with bone or cartilage, and use tissue sealants. Sometimes a multi-layer closure with vascularized mucosal flaps is done. Lumbar CSF drainage can help, but it also brings extra risks. Transsphenoidal surgery is not always straightforward. Tumor capsules can be fragile, making removal tricky. Strong adhesions to the diaphragm or pituitary stalk can make complete resection difficult. In some situations, surgeons leave a small portion of the capsule intact to avoid damaging critical structures. Safety guides every decision. Suprasellar extraventricular tumors sit just above the sella, but outside the third ventricle. Accessing them requires careful planning. Surgeons choose approaches based on tumor size and position. Some approaches are minimally invasive. The endoscopic transventricular method goes through the ventricles. It's mainly used for cyst drainage or catheter placement. Another option is the supraorbital route, where a small opening above the eye lets surgeons reach the tumor. Open approaches give wider access. The terional route starts near the temple. A unilateral or bifrontal craniotomy opens the skull from the front. Skull-based techniques, like the orbitozygomatic or transpetrosal approach, are used for deeper or more complex tumors. Each method aims to reach the suprasellar area directly, while limiting unnecessary brain exposure. Surgery choice is a balance. Surgeons weigh tumor size, location, and patient factors. The goal is safe removal without harming surrounding structures. Each method has strengths and limits. The endoscopic transventricular approach is a minimally invasive route for tumors inside or close to the third ventricle. Surgeons go through the lateral ventricle, usually via the foramen of Monro. It's mainly used to open cysts or place catheters. Brain retraction is much less than with open craniotomy. Careful handling of the fornix is essential because damage can affect memory. Next, the supraorbital approach also minimizes tissue injury. The surgeon makes a small incision along the eyebrow. The bone flap is about 3 by 2 centimeters. This method keeps soft tissue damage low and gives a better cosmetic result. But it has limits. The frontal sinus can be involved, vertical reach is small, and brain retraction is tricky. There is also a risk of CSF leak if the sinus is breached. Both approaches aim to reach the tumor while sparing the brain. Each has trade-offs, and the choice depends on tumor location, size, and patient factors. Safety is the main goal. The terional craniotomy is one of the most commonly used approaches for craniopharyngioma surgery. It starts with a frontotemporal craniotomy, and the sphenoid wing is drilled to allow access. This approach is versatile and widely adopted because it provides several ways to reach the tumor safely. Surgeons work through key corridors. The pre-chiasmic space lies between the optic nerves, the anterior chiasm, and the sellar tubercle. The optical carotid triangle sits between the lateral optic nerve, the chiasm, the supraclinoid carotid, and the first segment of the anterior cerebral artery. Lateral to the carotid artery, the lateral corridor gives another path for dissection. Each corridor is chosen depending on tumor location and nearby structures. One major advantage is direct visualization of the suprasellar blood vessels. This allows careful dissection of small perforating vessels, the optic apparatus, and hypothalamic structures without unnecessary stretching of the brain. But there are limits. Tumors behind the ipsilateral optic nerve can be hard to reach, and excessive manipulation of the optic nerve can cause vision problems. Surgeons sometimes use adjunct techniques to improve exposure. Sectioning the falciform ligament, decompressing the optic canal, or removing the anterior clinoid can help create more room and reduce strain on critical structures. The goal is always safe access while protecting vision and hypothalamic function. The bifrontal craniotomy starts with the patient lying on their back and the head slightly extended. The incision is made behind the hairline, keeping it out of sight. Burr holes are placed near the superior sagittal sinus to begin opening the skull. Surgical access is gained through the anterior interhemispheric corridor. This path allows the surgeon to see the optic nerves and the optic chiasm. It also provides a view of the suprasellar region and through the lamina terminalis, the third ventricle. The corridor gives a straight line to midline structures while limiting unnecessary brain retraction. This approach has key advantages. It provides excellent exposure along the midline and is especially useful when the optic chiasm is post-fixed. Tumors extending into the third ventricle can be reached more safely. But there are limits. If the optic chiasm is prefixed, access is more difficult. Very large tumors may need extra exposure or additional approaches to reach all parts safely.
The goal of the bifrontal approach is clear visualization and safe dissection. Surgeons balance access with protection of critical structures to reduce risk of neurological deficits.
Surgery for intraventricular or combined tumors often uses the transventricular approach. This route is important for craniopharyngiomas that mainly sit in the third ventricle. It is preferred when obstructive hydrocephalus causes the lateral ventricles to enlarge. Access to the lateral ventricle depends on ventricle size. When the ventricles are dilated, the transfrontal route is chosen. The patient lies on their back with the head in a neutral position. If the ventricles are normal or small, surgeons may use the interhemispheric approach. Here, the patient lies on their side, with the operative side down and the head slightly raised. The operative corridor enters through the foramen of Lonro. Subchoroidal dissection can widen the path to the third ventricle. This allows the surgeon to see tumor margins clearly and view the walls of the hypothalamus. Careful handling of the fornix is critical because injury can cause memory problems after surgery. A ventricular catheter may be placed when needed. This is considered in cases of preoperative hydrocephalus, significant bleeding during surgery, or when a residual tumor blocks cerebrospinal fluid flow. The goal is safe tumor removal while protecting brain function and minimizing complications. The translaminar terminalis approach gives access to the anterior part of the third ventricle. It allows a direct view of tumors inside the ventricle, but the posterior third ventricle is hard to reach. Visualization can also be limited by the optic tracts and nearby blood vessels, which makes careful navigation essential. The transcallosal approach enters through the corpus callosum, then the lateral ventricle, and finally the foramen of Monro. It provides excellent views of the superior pole of the tumor. However, the inferior portions can be difficult to reach. Handling the fornix is delicate because injury may lead to memory problems. The thalamostriate vein also requires careful manipulation to prevent bleeding or neurological complications. Both approaches aim to maximize tumor exposure while protecting critical brain structures. Surgeons choose the route depending on tumor position, size, and the surrounding anatomy, always balancing access with safety. Tumor removal starts with cyst decompression if a cyst is present. This reduces pressure and makes the solid portion easier to handle. Next, the solid tumor is removed piece by piece, rather than trying to take it all at once. Dissection is done carefully around critical structures. The optic nerves, carotid arteries, and pituitary stalk are handled with great care to avoid injury. Every movement is deliberate because even slight damage can cause vision problems, hormonal imbalance, or other neurological deficits. The overall goal is safe tumor removal while preserving function. Surgeons balance thoroughness with caution, aiming to take out as much tumor as possible without harming surrounding structures. Surgical planning must be tailored to each tumor. Size, location, and how far it extends determine the approach. No single method works for every case. The main goal is complete removal whenever it can be done safely. Safety comes first. Resection is stopped if the tumor sticks to the hypothalamus, optic nerves, or major blood vessels. Surgeons take great care to protect the optic nerves, hypothalamus, small perforating vessels, and the pituitary stalk, because damage can lead to serious deficits. When total removal is risky, an alternative strategy is used. Subtotal resection is combined with radiotherapy to treat residual tumor. Even then, recurrence may happen because microscopic tumor cells can remain hidden, so careful follow-up is essential. The principle is simple. Remove what is safe, protect what is vital, and plan for what cannot be safely excised. Every decision balances thoroughness with caution to achieve the best outcome for the patient. Postoperative monitoring focuses on detecting complications early. Some problems appear soon after surgery. Others develop over several hours. The aim is simple: identify changes quickly and act before they become severe. Hypothalamic failure is one important concern. It can occur when the tumor was tightly attached to the hypothalamus, and surgical separation places stress on this region, which controls temperature, consciousness, and many basic body functions. Patients may show altered awareness, seizures, or very high body temperature. This is serious.
Continuous neurological observation and strong supportive care are essential during this period. Fluid and electrolyte control is another key area of monitoring. The surgical field sits close to structures that regulate water balance, so disturbances can appear after the operation, especially when pituitary signaling or hypothalamic regulation has been disrupted. Clinicians track fluid intake, urine output, and blood electrolyte levels, while also measuring serum and urine osmolality when imbalance is suspected. Diabetes insipidus may appear early and is managed first with fluid replacement, and sometimes with antidiuretic hormone if urine loss continues. Hyponatremia can follow later. It may arise from SIADH or from cerebral salt wasting. Bleeding is uncommon but dangerous. It usually appears within the first 24 hours after surgery. A sudden neurological decline or worsening headache may raise concern. CT imaging is used to confirm the presence of a hematoma, and if bleeding is detected, the clot is removed promptly through surgical evacuation. Persistent hydrocephalus can also develop after tumor removal. In this condition, cerebral spinal fluid flow remains blocked, which raises pressure inside the skull and can produce headache, vomiting, or declining alertness. Monitoring is therefore critical during the early recovery period. When hydrocephalus continues, a ventriculoperitoneal shunt may be placed to divert fluid and restore normal circulation. Steroid therapy supports endocrine stability and reduces swelling. Hydrocortisone is given for physiologic adrenal replacement, particularly when pituitary function is impaired, while dexamethasone is used to limit cerebral edema around the surgical area. These treatments help stabilize the patient while the brain recovers from the procedure. The overall objective is early recognition and rapid management. Small changes can signal major complications. Careful monitoring, timely correction, and coordinated intensive care greatly improve postoperative outcomes. Outcomes after craniopharyngioma surgery vary widely. Reported rates of complete tumor removal range from 10 to 90%, with an average around 58%. Surgery alone does not always guarantee long-term control. Tumor recurrence is a reality. Even after gross total removal, recurrence can happen in 6 to 57% of cases. Visual problems occur in a small but significant number of patients, roughly 6 to 19%. Endocrine issues are more common, affecting half to all patients, reflecting the tumor's close relationship with the pituitary and hypothalamus. Perioperative death is rare but possible, ranging from just over 1 to 10%. These risks are linked to the complex anatomy of the suprasellar region and how close the tumor lies to critical nerves and blood vessels. Every case requires careful planning to balance thorough tumor removal with preservation of function. In summary, surgery remains the cornerstone of craniopharyngioma treatment. Success depends on careful selection of the surgical approach, while protecting critical nerves, blood vessels, and hormonal structures. When complete removal is unsafe, adjuvant therapies are used to manage any leftover tumor. Balancing tumor control with preservation of neurological and endocrine function is vital. The goal is to treat the tumor effectively without causing vision problems, hormone imbalances, or other complications, always weighing risks against benefits. For more high-yield neuroscience education and clinical tips, join the StudyNeuro community. Follow on YouTube, Facebook, TikTok, Instagram, and X. Like, comment, share, and subscribe. Thanks for watching. Stay tuned for more practical insights in neurosurgery.